Thank you very much. Thank you for the kind invitation. I work in the Balkan Medical Center also in Pokratou, Thessaloniki. So we will change the topic, and thank you for being here. It's getting late. I hope you will find this presentation interesting. Just to give you a background, my original research and PhD was in TAVI, but then I made a switch. So I focused my research in left atrial appendage occlusion, and I will explain to you in the next 10 minutes why and why you may consider this therapy. The main issue and one of the main global health problems right now is the stroke and the disability related to stroke. And the cardioembolic strokes that we usually have to deal with are usually the most disabling and the most serious, as you see here. So I'm sure, we are all in the field of cardiovascular disease. There is a long standing battle against stroke, but whenever we try to reduce stroke, we increase bleeding. And there is a limitation of the medication, and this is shown in different ways, and mainly, as you see here, even with the introduction of the new anticoagulants, the non-vitamin K anticoagulants, which are not new anymore, the adherence and the use of these drugs in the general population didn't actually increase too much. So I just fished one little publication from the in New England Journal of Medicine in the arterial trial. And this is not about the clinical subgroup of patients. It's about when you lower the risk of stroke, as apixaban did in this study, there is a higher risk of bleeding. So I think we reach a threshold there. And as in many other things in life, there is no free lunch. You give something, you take something. And the reality is that the annual major bleeding rate for in anticoagulation is close to 5%. And what happens next? The patient gets a bleeding, he's hospitalized, and then what? Out of, let's say, 3,200 patients in this very well-conducted study, we saw that 10% had an yearly major bleeding event. So this is huge. And what happens is that these patients, they suffer from clinical endpoints like stroke, myocardial infarction, cardiovascular death, etc. And this happens early after their original hospitalization for this bleeding event. And the main reason is the discontinuation of therapy. So all these seems logic, but sometimes we tend to forget the elephant in the room, and we talk about other things. So the adherence of anticoagulation medication, even in the best and well-designed clinical trials, reaches 50%. Okay, so what about the new drugs, the anti-11 factor drugs? Big hopes there. Unfortunately, we have signals also from this field that there is a plateau. The trial of the Oceanic AF study was stopped because the medication was not effective, actually. The bleedings were less, but they didn't really prevent stroke. Again, no free lunch. So we see that left atrial appendage occlusion has started to appear in papers, in publications, mainly coming from the US. As you see here, we have some patients that when they get discharged, they are offered this procedure. However, the European guidelines are still in a 2B indication. And the main reason for that is that we don't have, the big randomized clinical trials. And sometimes the reality is faster than the trials. But this is the situation, 2B. Now, in the surgical field, I will show you the LAA3 trial. There was some evolution. And on the other side of the Atlantic, we have seen the change of the guidelines to a 2A indication very, very recently for this procedure. The LAOS trial, as I mentioned, the very well-conducted surgical trial showed that concomitant combined LAA closure, surgical closure with other procedures is beneficial for the patient. And I will just want to show you a few indications that sometimes are not considered because we don't think about it. And you see there group A, which is the most reasonable, the contraindication for long-term anticoagulation, but we also have the second group of patients where patients take the medication, they take it properly, and they still suffer from stroke. So this is a stroke on anticoagulation, for several reasons. And when we document that this patient had a thrombus in the left atrial appendage, this patient may be considered even for closure with a different technique, and I will show you how. So this is the consensus paper that's trying to explain what the guidelines don't explain, and make us think that some patients should be offered this therapy after careful examination. And this is a practical guide for the long-referring physician that we just recently published in a European effort to increase the awareness for this procedure. And this is a schematic approach, a schematic way to show which are potential candidates. Now, and also we have this algorithm showing that when we have high bleeding risk, one of the things that we should consider is this procedure. Now, years ago, when I gave this lecture in TCT, we were worried about complications. We still want to know the patient, master the technique, and know the device, but right now we have changed, this therapy has changed, and now we talk about optimal closure. And this reminds me a lot of the early years of TAVI, when we talked about the depth of implantation and different things, and paravalvular leaks, etc. Now, there are two issues still. One is the device-related thrombosis, and the second is the peri-device leak. And we are working on that. Now, for the peri-device leak, we were honored to publish this meta-analysis recently in the European Heart Journal, showing that any leak of more than 3 millimeters is bad. That's as a take-home message for you, and briefly, and that the leak should be detected by TEE and not by CT, because CT will show occasionally contrast in the distal part of the appendage, but this doesn't mean there is a real communication that is clinically relevant. Now, what about the DRT? We had the problems with the definition of the DRT because it was confused, people get confused with the healing process that we see on CT. Now we know that there is specific definitions of DRT, plus, just to remind you the TAVI days again, the depth of implantation. We intended to implant the devices deeper, and now we know that this is bad. This creates a slow flow environment that creates DRT. So these were published recently and were shown in EuroPCR lately. Another new thing is the idea of giving, instead of dual antiplatelet therapy for 1 to 3 months, because we wait while waiting for the device endothelialization, or single antiplatelet therapy, we don't do full dose anticoagulation, to give half dose apixaban. And this is a very nice small study shown last year in EuroPCR, that half dose apixaban may be the best drug for this short period of endothelialization for the first months after LA closure. Now, with this therapy, we need to collaborate with other specialties, neurologists, gastroenterologists, you name it. And this is a very interesting presentation that I borrowed the slides from, talking about intracranial versus extracranial bleeding and how bad this is for the patient, even in the big randomized trials with NOACs, and bringing the issue of microbleeds in MRI in our attention, which magnifies the risk for intracranial bleeding by 10 times. So we prescribe the drugs as cardiologists. The neurologists see the intracranial bleeding, but nobody can check for primary prevention. And this is a big problem. Now, I will move forward to adherence to anticoagulation. We published this paper a few years ago. I just want to show you this. In 1,000 patients that are hospitalized with atrial fibrillation in a Greek hospital, 13% had a previous major bleeding, and almost half of them don't take their drugs properly, their adherence. And I think this is very similar in other hospitals. So the patients are there. One word about the resistant stroke. There is not much data. We have this data from the ACP registry that showed that these patients usually are have more comorbidities, but at the end, their outcomes are similar to the rest of the patients. Now, should we close the appendage in the presence of thrombus? In principle, no, but again, it depends. It depends on the anatomy, it depends on whether the thrombus is proximal or distal, the experience of the operator, and what are the alternatives for the patient. For example, this is a case I wouldn't do. But again, this is a dynamic situation where the thrombus may change. So this is the same patient before and after magnification of the anticoagulation, and actually we're going to treat this patient on Monday. How? You need to apply some special technique. Be careful. We don't give injection in the left atrial appendage. And the only barrier is that you can do a single shot. You only have one chance to do the implantation. You cannot just try again and again. But it can be done. I just want to mention that, so this is not an absolute contraindication. Now, what about the non-randomized clinical trials? The most important trial right now is the Champion AF. They randomized up to 3,000 patients, and this is the enrollment has finished in all comers. Here we don't have patients with contraindications to anticoagulation. It's all comers, patients with AF. And we expect the results to come next year. In parallel, there is a Catalyst trial sponsored by Abbott with another device with an amulet. There the enrollment has been slower, but we will expect the results in a similar, probably a year later. In the meantime, and the upcoming trial that will be shown, presented in AHA this year, is the combination ablation plus LA closure versus ablation only, the option trial. On Friday, actually, we did the first combined pulse field ablation in Hippocrates Hospital. It was a very smooth procedure. We did the transeptal. The EP people did the pulse field ablation. It took them an hour, and then at the same time, we implanted a Watchman device. Now, another trial that is coming is the closure AF. I will just want to be brief. Plus the LAOS 4, Watchman Flex, in addition to oral anticoagulation, on top. So just to make you think. Now, what's the comparison with TAVR? It's a smaller market for sure, and this is a very easy research I did. But the growth is double. So this is a procedure that is probably here to stay as long as we increase our technique and also we have more data. So in conclusion, cardioembolic stroke remains a leading cause of morbidity and mortality. Percutaneous left atrial appendage occlusion offers the option of local therapy versus systematic. For surgical closure, we have very clear data that it's beneficial for the patient. We have results from large registries that are very promising and some new randomized clinical trials coming along. And this is a procedure that its number is expected to grow exponentially during the following years. And with that, I hope I explain why I'm here talking about LAA closure in a heart valve meeting. Thank you.
Thank you very much, Dr. Tzikas. Very nice lecture. Congratulations for your work on this field. Of course, it's still a problem in question what the thrombotic therapy these patients will need for the first period after the closure. It's for 3 months or for 6 months, antiplatelet only, anticoagulant. You saw that they're doing a trial that they're giving anticoagulant on top. So it's a bit paradox. We do the whole procedure to avoid the anticoagulation, to avoid intracranial bleeding, but then we have in the strategy the use of anticoagulation.
So the trial that I showed at the end is something totally different than LAOS 4. When we do the procedure, we wait for device endothelialization. So for 1 to 3 months, you need to give something.
Right.
Usually it's single antiplatelet therapy, maybe half dose NOAC. But the benefit comes later, after 2 or 3 months, when you can stop everything. Now, the trial that I showed is for another patient population. We're talking about all comers. We're not there yet.
That interesting study you showed about the detection of microbleeds by MRI is in practice? I mean, you perform regularly?
No. And I asked the neurologists, and neither they do. So we just prescribe the medications as cardiologists without knowing.
Also, and it's difficult.
So there is a trend in the US now to screen for microbleeds in patients before getting anticoagulation, but it's still there is no real guideline on that.
And also, your initial comment regarding the 11A inhibitor was a bit negative. I would say it may be a good option in cases that you want to achieve some level of anticoagulation, but without having bleeding risk. Actually, instead of using apixaban 2.5,
yeah,
why not
we still need to use
an 11A inhibitor, which will be rather safe regarding bleeding and do at least some protection.
Maybe that's a nice topic for a study, maybe.
Professor
Apostoli, yes. Apostoli, thank you very much. Excellent. As usual, you have, you know the topic, you know the field. To bring in a discussion, because, you know, your concerns are why we don't have this, you know, widespread use of the devices. And I would say that a question that I have, and I believe a lot of us have it, is, okay, if you have a low-risk patient for stroke, okay, you know, you have a good candidate, you can use, you know, your device and will be equal effective, trials have shown, to giving oral anticoagulation. But I'm not sure that we are all convinced that if you have a very high risk for stroke, you know, patient with congestive heart failure, you know, remember we keep on saying that it's not only the local effect, it's all the vascular, and that's why maybe anticoagulation, you know, you need it. Yeah. And so this is a group of patients that I'm not sure that I feel comfortable to, okay, I put the device and that's it, you're done.
Yes, I agree with you. That's why patient selection is important. There are so many different kinds of patients out there. So we need to think, I agree. But what we have seen is the clot that is coming from the left atrial appendage and the AF-related strokes are very disabling. These are big strokes. And you have seen that clots with PFO and other strokes may be less disabling. So what we have seen, after closing the appendage, and we did a study, we have some strokes that are minor. So the concept in my mind is that at least we avoid the big reservoir of big clots and thrombus of the appendage. And but of course we need to prove that.
Congratulations for your excellent presentations. I'd like to thank you personally for all your valuable assistance in the cases we have performed in a year hospital. What I would like to say is this: you showed that thrombus formation inside the appendage is, let's say, a relative contraindication. Are there any major issues regarding patient selection, anatomical features, concomitant diseases, access that will really avert you from going through the procedure?
Yes, this is a good question. The size of the appendage is one, but usually this we see in Asia. For some reason, the Asian people have larger appendices, but there are dedicated devices. Another reason is the presence of a big ASD closure device, and this is what we discussed with Dr. Tzifa a few weeks ago here. You close the door, you don't do anything, you have a big ASD closure device, and these patients have AF. Another reason would be the presence of thrombus that is mobile and it's, you know, hanging there. We don't do the case. But I would say it's less than 1% the patients that are excluded because of this. And valvular AF. Valvular AF, which means mitral stenosis, that's another story. Then the thrombus, 50% is from the left atrium. So I did one, I closed one with thrombus, and then I have the thrombus on the device. So we need to talk about non-valvular AF, no mitral valve stenosis. Yeah, and I think...
Professor Scalidis.
Yeah.
Thank you. An excellent presentation in a topic that we don't know well. I want to ask, you said that it's bad to have 3 millimeters, more than 3 millimeters flow in...
A leak.
Yes, a leak. How common is and how do you treat? What do you suggest?
Well, to be honest, if you do it properly, it's very, very uncommon, depending on which device you use. That's why we need to have more than one device in our cath lab. It's the same as the early days of TAVI. Same thing, it's like a déjà vu. If you do it properly, that's not a problem. But the problem we have now is in the US, mainly, which is the market has exploded, that people do 10 cases in one day, and they don't care so much about these leaks. They say, it's okay. So the message is to them, don't worry about that. In Greece.
Last question from...
Small comment, congratulations for your talk, your experience. I think we undertreat patients now in Greece compared, I want a simple comment on that from you. And also we're seeing in abroad that they're doing concomitant implantation of the occlusion of the LA with, for example, AF ablation, you do the transeptal, you can do the implantation even after mitral clip in some cases, not in all. Any comments on that?
With the mitral clip, I'm not very happy to combine, to be honest, because there is some degree of mitral stenosis. I'm not sure if this is mitral stenosis situation. I'm not sure. It has been tried in Switzerland, with fairly good results, but this is a population that would not be my first choice. But for the combination of AF ablation plus closure, after the publication, hopefully the option trial is positive in AHA, things will change dramatically on the EP side because you are there. I mean, the appendix is in front of you. It took us 8 minutes to close this one on Friday.
Okay, thank you very much, Dr. Tzikas. Last speaker.